Hello and welcome everyone. Today we have another lecture of Principles of Surgery course, and we will talk about the management of lung cancer. And I'm happy to introduce our today's speaker, Dr. Gita Mody. She is a professor of surgery at the University of North Carolina. She is a director of Thoracic surgical oncology, expert in surgical interventions for lung cancer, including minimally invasive thoracic surgery, and the management of patients with end-stage lung disease, including transplantations. Thank you, Dr. Mody, for joining us today, and please feel free to begin your presentation.
Well, thank you, Svetlana, for the introduction. I'm very happy to be able to participate. I would just like to ask a question by show of hands. How many are performing lung resections in the audience? Dr. Bjorski, have I said it properly?
Yes.
Yes. Okay, thank you. And tell me, please, what types of conditions are you treating with lung resection?
I'm working in thoracic department. So lobectomy, pneumonectomy.
Mostly for cancer?
Yes, mostly for cancer, maybe 80 or 90%.
Mm-hmm. And what type of approach do you normally take? Is it minimally invasive, open, or some combination of that?
We actively improve our mini-invasive surgery, but it's not enough this endogia staplers. So
yeah,
we perform open surgery.
Sure. It's a common issue. It's not the technical expertise, but rather the materials. Because to do thoracoscopic surgery, the staplers need to be available. I only ask so that I can understand how to contextualize the information. Dr. Melnichuk had invited me based on us knowing each other from many years ago when we were just surgical interns together and we had done some training time together. And then she knows that I, for now 20 years, have been involved in outreach to lesser resourced areas of the world, primarily East Africa, some in South America and India. But this talk today is, of course, applicable globally. And so I hope it'll be useful, but please feel free to ask me questions in between or tell me to take a different direction. I'll try to wrap up to allow 10 minutes of questions and we'll end just before the hour because I need to go to another meeting after this. So again, thank you for the introduction. You can see my slides, everyone. Yeah, okay. We'll try to move. Yeah. So the objectives are to review the role of surgery in lung cancer care, discuss some landmark surgical studies, and explore perspectives on the future of the field. In our area, some of the advances have been in using neoadjuvant therapies to treat tumors that are stage 2 or greater prior to surgery, using localization technologies to find smaller and smaller nodules, and other types of innovation. But I'll just start with a very classical case presentation. This person was a smoker, 58-year-old woman, and had a car accident, MVC. A nodule had been seen and was followed, and it had enlarged. So we were concerned, of course, for an early stage lung cancer. The patient, unfortunately, was lost to follow-up and did have symptoms. Subsequently, a PET was done showing that there were avid hilar and there were some altomediastinal lymph nodes. So this was now more concerning for an advanced stage. That just motivates the topic. We'll begin actually with global epidemiology of lung cancer. I'm sure you've seen maps that show the distributions of cancer mortality worldwide. What are the reasons for mortality in most westernized areas are cancer and heart disease. But this is actually becoming a more substantial problem in other areas like Northern Africa and some areas of South America as well. This is cancer in general. And then, of course, in countries where infections are still problems and there's more premature mortality due to other reasons, cancer is a lesser cause for worldwide mortality. If we break it down by men and women, of course, prostate cancer is the most common incident cancer in men, with lung cancer following. But as you well know, the most common reason for mortality is lung cancer. It often presents late stage, and as we know, survival even after therapy is determined based on the aggressiveness of the tumor. Women, of course, breast cancer is most common, but again, the lung cancer is the third most leading cause for mortality in women. And I think we'll see over time that these trends will continue as the patients who had been smoking now become older in age and have higher risks to be found to have lung cancers. I don't have this breakdown of cancer cases and deaths for the global population, but we can use the US as an example country. And again, the number of cases per year are more than 200,000 with both genders combined, and the deaths are greater than 100,000. What's the lifetime risk, like a way to get a patient to understand how likely they would be to have cancer? Slightly higher risk in men, probably because of smoking incidence in terms of epidemiology, but also a 1 in 17 risk in women. And of course, there of cancer deaths, it's 1 in 5 cancer deaths. So a substantial cause for death, a really important problem. Usually patients are 70 years of age on average. Good news is that new cases and deaths as well are decreasing, largely due to what I talked about before, where advances in smoking cessation, earlier detection, and treatment in terms of therapies. This shows you the age standardized rates for lung cancer, so taking into account the mix of the population. And I think we can use, let's see, Eastern Europe, I suppose, would that be the most appropriate category? Yeah. And you can see it's quite high. My understanding is that this is driven by a particularly high incidence in certain countries. I think the heavily smoking countries, for example, Hungary, is very high rates of smoking. I don't know what it is like in Ukraine, but I think we can use this rough rate incidence per 100,000 similarly. I think it would probably apply if you agree. So what are the risk factors? Who should we be watching out for, and how does the tumor develop? We are very familiar, of course, with both smoking and secondhand smoke. The next most common risk factor is family history, and then any air pollution, whether it's smoke from cooking fires that are poorly ventilated or from industrial pollution, like it might happen in some parts of India. Radon gas and asbestos, all linked in observational studies to lung cancer development risk, at least. So these were again observational studies, and the first one pointing out how radon could be linked to lung cancer was in 1879 in Germany. But then, of course, the tobacco industry came along, and at least in the US in the 40s and 50s, this became an emerging concern. There are some genetic predispositions to lung cancer. Some people may be more at risk for nicotine addiction or for development of cancer if they're smoking because of polymorphisms. And COPD itself has been shown to be linked to the risk of lung cancer, probably due to some architectural distortion of the tissues there. I think that the rates are decreasing, and that's good news. This graph kind of nicely compares the rates of previously smoking to currently. As you can see, everywhere in the world, it's coming down, essentially. So I don't know if we use another country from the region, but maybe 30% of individuals are smoking in the present day. Anyone want to tell me in Ukraine, what do you think is the rate of smoking amongst, let's say, adult males? What would you estimate it as?
It's hard to be honest. Maybe 20, 30%.
20, 30. Yeah. Do you think
Agree.
rates are decreasing or increasing?
Decreasing.
Decreasing. Yeah.
Yes.
Due to educational campaigns and things like this? Yeah, great. We went through the risk factors. When we look globally in less developed areas, maybe some infectious concerns like HIV may be more relevant. There can be higher rates of COPD in patients with HIV, and then also higher rates of cancers, including lung cancer. Okay, I think this is all review for you, all your practicing surgeons. But as you know, the major histologic type for lung cancer is non-small cell cancer, which further divides into most commonly evenly squamous cell and adenocarcinoma, and then large cell cancer. And then a smaller number of lung cancers are small cell lung cancer. This is that 15%. It's a much more aggressive form. There are other tumors of the lung, but we'll use these basic categories to understand surgical management. So what happens, right, when you get the smoke or radon or pollution exposure? There can be dysplasia of the epithelium and then mutations. Some of them we know about because they actually can be targeted. For example, EGFR can be, if that's a mutation in someone's lung cancer, can be treated. There are probably many more mutations that we don't know about. We haven't named them. And there are more identified mutations than there are treatments, though that's also hopeful for the future. Molecular targets will be identified, but then ways to treat them would be developed, and this may drastically improve survival rates as time goes. That's also a hopeful thing. So smoking is going down, and therapies, including targeted therapies, are being discovered. What is the usual clinical presentation, and then how do we stage? Obviously, Dr. Biarski is very familiar with staging, but I would presume not everyone stages lung cancer all of the time. If this is repetitive, just tell me if you already have this in your practice. But you know, the symptoms for lung cancer are very non-specific, maybe a cough, maybe a little hemoptysis, but most typically there's no symptom because the tumor isn't yet advanced. And of course, the symptoms may be also common to other types of diseases that cause lung nodules. So TB would also cause coughing up of blood, fatigue, and weight loss. Very non-specific. And in fact, you know, they love to quiz the students on the paraneoplastic syndromes. I just show it because look at how complex all the things are. But these aren't the most common presentation. What would have to happen is that the tumor is secreting a biologically active substance. And then in those cases, for example, I had a patient who had ACTH secreting just a little 1 centimeter tumor. And they certainly had, you know, the phenotype of Cushing syndrome with the humped back and moon faces and things like that. But it's not as common as the very, you know, late presentation of the local growth, where you get a little pleuritic chest pain because the tumor is coming to the pleura. Or, you know, if it's a large, fast-growing squamous cell obstruction or compression of the local site. For example, on the left, compressing the recurrent laryngeal nerve, or on the right, maybe growing into the apex and causing brachial plexus syndrome or SVC syndrome. So I just show that to say that even though there are classical clinical findings, early stage would not present with anything on exam unless it's one of the rare ones presenting secreting a hormone. Okay. Questions about this or any input? Okay. So in US, and I'm sorry that I don't actually have this information for your region, but it would be very interesting to know about the cancer registries and how the tumors are presenting. But the split is half are early and half are late. Okay, so 17% have localized disease, 20% may have a regional situation, and then 50% are presenting late stage. that's what makes the overall survival for lung cancer, which unfortunately is still overall survival for lung cancer cases, 15%, because more than half of them are presenting in a late stage, okay? As surgeons, of course, we're seeing the localized and the regional cases because we can treat them, whether it's with surgery up front or surgery after a neoadjuvant treatment. Of course, the prognosis for a localized tumor is much better. When all the subcategories of stage 1 are put together, 60% survival rate. And of course, it's better if the tumor is small, has a good histology, and no concerning other features. So it's interesting, since I made this talk, you know, the 9th edition of the AJCC staging system has come out. So I'll have to update this slide. I don't think there's major changes based on the size and lymph node stations, but of course they tweak the system because the idea is to put together cases, stages, sizes, and nodal status that have similar survival. And so this was what I was pointing out, is that if the tumor is stage A1, which would be a small, less than 1 centimeter tumor, the 5-year survival is actually quite a bit better, closer to standard life expectancy. But whereas when you get to the 1B range, where the tumor is already going over 3 centimeters, this survival is less. You become stage 2 if there's any lymph node involved, and the hilar region, stage 3 if there's any mediastinal lymph node, and then of course 4 is metastasis, and you can see the declining rates of survival based on that stage. So this is just to review. So how many here are familiar with the mediastinal lymph node stations? I don't know how many would use this in their practice for any reason. Yeah, of course, Alexander, you're got it. Okay, so is it helpful to just look at this briefly for the rest of you? Yeah, because maybe it's been some years since when you were. So if, let's say you're practicing general surgery, if I wanted to do mediastinoscopy to evaluate, sorry, I'm pointing as if you can see me pointing, you know, evaluate these lymph nodes here on either side. I'm doing that later this afternoon. I make the incision just here over the lower part of the trachea and use the video mediastinoscope to go down. And that gives you an idea. The diagram is showing it, yeah, here. Okay, so above the azygos, you'd have like a level 4 lymph node. Below the azygos, you can call a level 10 lymph node. And you can really sample with mediastinoscopy, basically the level 4R, the level 4L, and the 7, which is subcarinal station. If you're very good, you can go a little higher or a little lower, but you see the point there would be to sample the mediastinal nodes. These are called N2 nodes, and this would change the stage to 3, depending on the size of the tumor. And that's why we use this map to understand in common language, just like with breast cancer. What station is the lymph node? And what degree of regional involvement does that represent, and therefore what stage are they? Okay. Also nice on the diagram showing you how much of a packed space it is, right? This would be the pulmonary artery crossing over here. Here's the aortic arch, and in fact, the nominate crosses over the trachea roughly in this area. Here would be the SVC, and of course you have to look when you're doing mediastinoscopy somewhere in here for the azygos vein to avoid causing an injury that can be significant. So this is the region of interest for a right upper lobe tumor, obviously. These are the ones we want to look at, and it goes from N1, N2, N3, depending on, you know, for mapping from the right upper lobe or right lower lobe. It doesn't matter. This is how you would call the stages. N1 if the hilar nodes are involved, should include the 7, N2 for the mediastinal, and then N3 for contralateral. Okay. So this is the rubric that gives you based on size. Currently in AJCC 8th edition, T1 would be up to 3, T2 up to 5, T3 up to 7, and then T4 larger or invasive. And then we just went over the map about the lymph node stations. So anyways, the patient came, they had the PET that was concerning for a more advanced, in fact, you know, clinical stage 3 cancer, and then they underwent workup. Now, obviously, workup can be non-invasive like imaging or more invasive like surgery. So we'll walk through what those things look like. Obviously, a good history and physical exam. Often when they come, they've already had imaging, and we're talking about the CT scan in the clinic. What's the size of the nodule? Which nodes are involved, enlarged or PET avid? Is there a pleural effusion, which would suggest metastatic involvement, or chest wall invasion, which would increase the T stage to T3? And even the CT scans catch the adrenal glands, which would be a common site for metastasis for lungs. So it scans all the way down. But after we review the CT, then we usually get a PET. It both tells us about the regional involvement and any metastatic involvement, except of course the brain, which has to be separately staged. And then finally, tissue sampling, which can be done in many ways. Are you doing transbronchial biopsy there, Alessandra, with the, let's say, EBUS or some other method?
We have EBUS only in a few cities, large cities in our country.
Large, what would you say?
We have only 2 or 3 EBUS in our country.
Yeah. Yeah, the EBUS, while it's a great non-invasive staging technique, they break rather readily. So I think you're doing mediastinoscopy for staging, correct? Yeah, yeah. I will add a picture of that for a future talk because that makes sense. Same we do in Rwanda, it would be mediastinoscopy. Again, in facilities that have it, if you had a station or a primary lesion that's amenable to CT-guided transthoracic biopsy, it can be done. Or the alternative here is to do a Chamberlain procedure where you go over the upper rib and come down onto the mass. Great. So let's say you do the, oh, here, yeah, I have the picture mediastinoscope. That's what we were talking about earlier for sampling. Very commonly used procedure. Let's just say there was some contraindication, like neck doesn't extend or you don't get the sample that you're looking for. You can also do VATS for sampling of the lymph node station. I actually now am doing my minimally invasive surgery robotically and really like the robotic platform for lymph node dissection. You really can zoom in and can take so many lymph nodes at all of the stations, essentially all of them except for 4L on the left. It can be very handy, and whether it's for lung cancer staging, probably not, right? Because you prefer to have them staged before you enter the chest, but it can be used for lymphoma workups and other problems like that. All right, now kind of the meat of the treatment paradigms, which have evolved a little bit. And we're going to just focus on, I guess I've got the small cell cancer first. So, Dr. Bjorski, would you ever operate for small cell cancer? Is that something that falls in the paradigm there?
Yes, we operated early stages.
Yeah,
of,
right.
of that.
Right. If you suspect it, obviously you have to be very aggressive because it can rapidly spread. But if it's isolated to a lobe or a segment and therefore early stage, it would be resectable with good outcomes. But obviously these patients need multidisciplinary consultation with both medical and radiation oncology because small cell cancer frequently metastasizes to the brain. They're given prophylactic whole brain radiation and also may spread systemically and so be considered for chemotherapy. There are some studies going on now about resection for small cell cancer. I don't think it's likely to change practice a lot. If you get lucky and find it so early, or let's say, it's a diagnostic consideration, you may get to treat it. But as a surgeon, I think that we're often not treating small cell because most of it is either locally advanced or has metastatic disease. I mean, the vast majority of it. Limited stage, meaning just in one area, not involving nodes and not involving any other structures, can be considered. And of course, the paraneoplastic syndromes are more common in these diseases, in the small cell cancer. Okay, I think we talked about getting systemic therapy for all the patients that they need to be worked up urgently, and that the prognosis is poor. So even with limited disease, small cell has a far worse prognosis than non-small cell cancer, and very poor survival when extensive disease. Any questions about small cell cancer? Again, this, I think I put it first because it's what we do less of. And so then we can now move to the non-small cell cancer here. Great. All right. So non-small cell cancer, a little bit about the history. The first pneumonectomy for lung cancer was in 1933. The lung cancer study group did a series of work in the 90s to establish lobectomy over wedge resection as the standard of care for early stage lung cancer. And we've actually largely practiced that way until, I don't know, maybe the last few years. Segmentectomy, of course, has been part of the armamentarium of a thoracic surgeon for some time, but usually being used for infections or metastatic disease where the margin considerations are less. But we've now had two studies which are important. The JCOG 0802 study, which was published first actually, and the CLBG study done by Nasser Al-Turki out of New York, which started a long time ago, but just took time to accrue patients, that compare the efficacy of segmentectomy, I should say sublobar resection versus lobar resection. In the JCOG study, it was segmentectomy versus lobectomy. But of course, one must remember that based on the epidemiology of tumors in this area, there may have been more non-invasive cancers than we see in our patient population. The CLBG study was wedge segment. So those two were sublobar versus lobectomy. And then they did post hoc analysis to compare wedge versus segment in that study. But both have shown that sublobar resection have equivalent survival to lobectomy. And of course, we can get into recurrence rates. We would expect slightly higher local recurrence rates with segmentectomy. But these are important studies, probably because primarily we're just seeing so many smaller tumors. And so if, I just was talking to a patient before I jumped on, who basically has a 7mm lesion that I'm following because it's just a little too small right now. It's 7mm in total size. The solid part is 3mm. Yeah, I think it'll increase and become 5mm solid at some point, but it's just rather small. So that's why I find it so useful to know about these data, because I think we should treat that disease a little differently than the case that I presented at the outset. Yeah, I think we agree. So, what's interesting here, Valerie Ruch, who's a very well-known and extremely prominent thoracic surgeon who's also engaged in global initiatives, wrote a very nice editorial in New England Journal of Medicine. She was the investigator on the original 1990s lung cancer study group study that put lobectomy forward. But I think we're talking about precision surgery for patients, right? What's right for your tumor at the stage that we know about it in the new screening era and all of this. Okay, let's go into, I had included some questions. This is from a prior talk I'd given to general surgeons that are based in eastern part of Africa. Go ahead, Dr. Bjorski, what would you like to say?
Thank you very much for your lecture. In which patients would you consider surgery with ipsilateral metastatic lymphadenopathy?
Okay, so if they have N1 disease, we now have a conversation. This is just in the last 2 years since the Checkmate study came. So if they have if they had N1 disease, but a T1 or even T2 tumor, they would be surgery first and adjuvant chemo. But now in the neoadjuvant era, we are discussing doing chemo immuno for 3 rounds, basically like 12 weeks of cycles, and then doing resection for N1 disease. Mm-hmm. What do you do in your practice?
Maybe N1 we perform surgery first.
Yeah.
What about N2?
Okay, that
And
depends on the how many levels. So same, I mean, actually in Europe, some centers are very aggressive, but we
yes,
we generally avoid bulky disease and we generally avoid multi-station N2. So single station N2, but always after neoadjuvant. What do you do?
bulky, no.
Yeah.
Maybe one station, yes.
Yeah.
After neoadjuvant chemotherapy, few stations.
Yeah, right. Right. Yeah, I mean, I think it depends a little bit on the age and functional status, but overall, if you have multi-station or bulky disease, that should go to definitive chemoradiotherapy. And if you have single station disease, neoadjuvant, usually chemoradiotherapy, then surgery. Now we would use chemoimmunotherapy. And we are doing that even in people who are low PD-L1 expressors, though the data may suggest that the higher expressors will have a better outcome. Actually, I'll say to be true, my lead medical oncologist would say that the PD-L1 expression rate does not predict what the outcome would be. It just makes intuitive sense that it would be better response to immunotherapy. But you see, these are nuances. And of course, things have changed. I again, before would have never considered anyone after doing mediastinoscopy to rule out N2 disease. I wouldn't have considered doing neoadjuvant in an N1 patient. But now stage 2 cases, so greater than 4 centimeters in size or N1 are being referred first for med-onc, then surg-onc. And we usually operate at about 3 weeks after the last cycle.
Thank you.
Yeah. Okay. So these are very easy questions. Again, it depends for everyone what their practice is about. The answers here would be surgery for a patient, choice. Question 1 is choice A, surgical resection, so long as the patient had no contraindications on PFTs. And then if they did, you could consider SBRT or segmentectomy for a patient with compromised pulmonary function. Oh, so sorry, the typo up there. I was just adjusting the slides last night. So in early stage cancer, obviously lobectomy is the first line of treatment. We should try to get either a wedge or a biopsy before doing lobectomy, because you would hate to end up with lobectomy and some benign finding. But sometimes you do have to proceed if those have been non-diagnostic or aren't feasible. Again, segmentectomy can be considered if less than 2 centimeters in size and negative hilar nodes. There is a little bit of just a nuance to throw in there. Sometimes people have done the study, well, what if you do segmentectomy in someone with poor pulmonary function, but the N1 is positive, and they've then shown that the outcomes are acceptable. But on the other hand, if I knew I had an N1 going in, I would make a different treatment plan for that patient, because I would in general feel segmentectomy may not be curative. Wedge resection can be considered when the tumor is peripheral and we don't think they'll tolerate lobectomy. Again, that all Torquay data, the CLBG studies suggest that a wedge can be done so long as the margin is wide and the lymph nodes haven't fully sampled. We're really trying to know how to absorb that, right? Previously, we would have said, gosh, you really have to at least do a segment. But sometimes, you have something way up here in the apex, and doing a wedge is just the same essentially as doing a segment. So perhaps the outcomes are equivalent, but one must take that with caution. And then we already kind of talked about this. When tumors are greater than 4 centimeters or there's an N1 node, chemoimmunotherapy must be considered. Also, if you find afterwards that the tumor were larger or the node is positive, you would offer adjuvant chemo for a marginal increase in survival rates. And then there's some, for example, if there's sort of a particular chest wall invasion pattern, sometimes for other ribs too, but usually we can go straight to surgery. And then finally, stage 3A and in some centers 3B, though we don't typically take 3B for operative management. We usually go definitive chemoradiotherapy. Questions about this? No. Okay, great. All right, so again, breaking down the stages that we are looking at, stage 1 and 2 primarily. We went over the tumor size and lymph node stations, as well as what defines the T. Okay, so let's just do a little comparison of surgical resection. And again, only if it's a stage 2 would you give adjuvant chemo, and only if margins were positive would you give adjuvant radio, which should be, you know, very unlikely or hopefully not often, versus SBRT. Now, I'll ask you this, Alexander, is there SBRT in Ukraine?
Yes. It's available, but no many centers.
So what would you do for a patient with a peripheral 2-centimeter tumor, but poor PFTs to tolerate?
Transthoracic core needle biopsy and then radiotherapy for this patient.
Radiotherapy or radiotherapy, yeah, that makes sense. Okay. In US, most of the patients are undergoing surgery, and that could also be due to, you know, are they close to the radiation facility or not? You know, do they want to keep going back? Though SBRT, the newer radiotherapy form, is very convenient for patients, usually just 5 treatments in 1 or 2 weeks, so it's less intensive for them. I included just a little bit of information. We have colleagues around the world, and you know, there's less known about lung cancer epidemiology, presentations, and therapeutic outcomes in countries outside of the West. But for example, a tertiary center in India, which was very high volume, reviewed their cases, and they found that only about 30% of their patients were following in a stage that could be treated with surgery, which is not unexpected. And in their center, only about 70% actually received any treatment. And that could be due to comorbidity, finances, or other problems. So we use the NCCN guidelines, and we've already walked through the CT, the PET, the perioperative evaluations, and biopsies. Let's go from the biopsy to the next stage. So let's say they had negative mediastinal nodes and we deem them operable, then we go to surgical resection and lymph node dissection. If medically inoperable, we use SBRT, and then depending on nodal status, chemotherapy. All right, approaches to thoracic surgery. So typically being done by minimally invasive approach. In the US overall, about half of lung cancer resections are done minimally invasively, about half open. And it's very concentrated in certain centers. So if it is a minimally invasive center, maybe greater than 80% of the surgery would be minimally invasive. If it isn't, that would be a lesser number, and then it averages out to about half and half, and that makes sense. You need to have sort of access to the equipment, as we talked about, and volume to maintain the minimally invasive approach. Very rarely would lung cancer resection be done through sternotomy, but it can be for upper lobe tumors or when there's some bilateral problem. We talked a little bit about wedge resection for peripheral tumors, segmentectomy for larger tumors but are still not centrally located, lobectomy as the gold standard, and for central tumors by lobes or pneumonectomies. Why do we decide, right, whether anatomically the tumor is amenable to resection and physiologically as well? So anatomically, metastatic patients are usually not resected unless they have, you know, an oligomet maybe to the brain or maybe the adrenal. Usually SVC syndrome, so invasion to a great vessel, contralateral positive node, recurrent laryngeal nerve involvement, effusions, or other types of mediastinal invasion are not resectable. And then, of course, we have to think about the physiologic status. So I don't know if you use ECOG or Karkovsky performance status, but an ECOG of 0 to 1, so they can do most things. Having adequate pulmonary reserve, in particularly having a post-op predicted DLCO more than 40%, and hopefully an FEV1 around 1 liter would be goals. Obviously, can't always guarantee that, and those patients would be at higher risk for pneumonia and post-op oxygen requirement. And then we don't routinely do cardiac evaluations unless they have known significant coronary artery disease or pulmonary hypertension. So I think the interesting thing about calculating post-op predicted DLCO and FEV1 is either you use it in practice and you already know how to do that, or you don't and there's no reason really to memorize it. But the way I sort of think about assessing pulmonary function is it really does matter what you're removing, right? A right upper lobe is not the same as a right lower lobe. Segments can be much more well tolerated than a whole lobe, those sorts of things. And so we use the segment count, 18 or 19, depending on what you believe in, right? There's 10 segments on the right and 8 on the left. And we use that as a way to calculate, okay, how many segments remain? And so of their predicted, percent of reference PFTs that they get, pulmonary function tests that they get, what will they be left with? You can use a rough rule of thumb that each lobe is about 20%, but because the perfusion is different in the upper and the lowers, and the number of segments are different, it can surprise you how readily someone would tolerate an upper lobectomy, but how poorly they tolerate lower lobectomy. And I'm sure you have that in your experience too. Yeah, okay. I just included a couple of illustrations, but in general, once you've done your access ports, whether it's low in the 8th intercostal space for robotic or triangulated for VATS, or posterior lateral thoracotomy, the hilum is exposed. You sort of do a circumferential pleural opening, dissect the lymph nodes at every station on the map that we saw previously. And then, for example, in right upper lobectomy, divide sequentially the superior vein, the truncus branch. You may find the posterior ascending branch in the fissure, and then finally the bronchus. Some people like to do it the flip of that, where they might take the bronchus first, then an arterial branch or two, and then the vein. But you can do it any way that it comes, is sort of that. And in robotic, what I found interesting when I changed over now about 3 years ago, it's kind of like an open approach, actually. You have to clear out all the lymph nodes very, very well to get around the structure, since you can't really feel, you can't quite push. It's all based on sight. So you have to really clean the lymph nodes out. But then after that, the sequence is quite like an open surgery. And you take a little bit of the fissure anteriorly and posteriorly, that you open the fissure and find the pulmonary artery branches, and then, take the other structures. Let's see what else we have. So one thing that's been nice about converting to robotics now several years ago is the ability to do segmentectomy. A superior segment's a fairly straightforward segment and probably, can be done VATS and obviously can be done open, but it's very nice robotically because you can see each of these structures individually. And you usually take the artery and then probably the vein and then the bronchus and then the fissure, like that. Outcomes after surgery, again, this is aggregated. I think we already looked at the outcomes. This was from an alliance trial and would differ based on T stage. Comparing to radiotherapy is hard because usually patients that are selected for radiotherapy are non-operable. There have been trials to bring in, so they're non-operable, obviously they're operable patients, but they don't accrue very well because generally patients want to go with the gold standard for surgery. And so in those patients that there was a study done on this, the comparison between overall survival to surgery was that at 4 years, the overall survival with SBRT was around 55%. So in general, what I tell patients is that, the early outcomes in terms of standard survival rates are likely equivalent, but longer term outcomes are not known in operable patient population, and recurrence rates are higher after radiation. That's why, in general, for patients who are good operative risk, we would recommend surgery. And I think that's the same for you there. Do you use adjuvant chemotherapy in your post N1 resections, Alexander?
Yes.
Yeah, probably platinum-based chemo, like carbotaxol or
Platinum duplet. Carbo cisplatin with second agent.
Yeah.
Like paclitaxel, pemetrexed.
Yeah. So, we tell the stage 1 patients they don't do better with that. And even in 1B, it's a little controversial. We don't usually give 1B, chemo, but if they have a greater than 4 centimeter tumor or an N1 node, we may recommend them to consult. Okay. So advanced disease, we touched on, how would you handle these T3N1s? Usually, again, if operable, we'll go straight to surgical resection in our center. T4 lesions too. Though I probably should update some of this for the chemo immuno, I'm realizing. I see that now. And then within 2 disease, as we talked about, it depend on how many. We usually try to initially stage with EBUS so that we can go back with mediastinoscopy for the restaging after neoadjuvant treatment. That's preferred instead of having to do MEAD again in the same plane. Okay, and N3 disease would be usually concurrent chemoradiotherapy with immunotherapy afterwards if they tolerate it. Can cause a pneumonitis, so patients 20% can't get through the regimen. Multiple pulmonary nodules, just keeping in mind if they're bilateral that the mediastinum needs to be staged before resection. And let's see here. Yeah, mediastinal staging and surgery. And if in the same lobe, we may go first to surgery and then follow with chemotherapy. Okay, so good news here is that survival is improving, and that gives us some new thoughts about post-treatment paradigms. We've been doing some research in my study group here to look at symptoms in patients after lung cancer surgery, trying to understand how long it takes them to return to their preoperative quality of life. As you imagine, there's quite a bit of variation in how people recover. Everyone's a little different. But in general, there's a lot of literature on symptom burdens after lung cancer surgery, and it demonstrates that pain and other symptoms like fatigue and even depression are very common in post-lung resection patients. Some people can get a chronic cough as well. And these things are predictors of how their quality of life is afterwards. So what are we doing for the future? I think we'll run out of time to talk about lung cancer screening. I wondered, let's just have a chat about that. Is screening for breast cancer common in Ukraine? I presume so. Yes.
Yes.
Yeah, colon and prostate as well, I imagine. Where is lung cancer screening falling?
2 months ago, our government discussed about lung cancer screening, and there is the document that it should be.
Yeah, it's hard actually because, first the studies have to be done to show that it improves outcomes, and that has been done. And then next we need to understand more about which patient group you know, and the interesting thing is you have to screen a high risk population, otherwise you'll have too many false negatives to make it worthwhile. But even this has been expanded to include wider age range and time from having stopped smoking. So we're modifying this as time goes. These are really detailed slides talking about how the low dose CT was demonstrated to improve lung cancer mortality and to stage shift, meaning earlier cancers were being identified more as stage 1. So I think there's enough evidence to support it. In particularly also, it's helping us identify these small little ground glass things I was mentioning, okay? There have been some trials outside of US, of course, sorry, but we don't have global standards for how lung cancer screening should be used. I'll skip over the immunotherapy, though, if you'd like to read this paper in particular, the New England Journal 2023, I believe it was. The lead author was John Spicer, and this was the study that showed us that the same immunotherapies we're using in melanoma can be effective to lung cancer, and particularly when it's still in situ. So that's why we use it neoadjuvantly. Okay. Now I do want to try to show one small video if I can. Now let's see how to do that. Let's get out of that. Let's change the share to this. Sorry, I'm talking out loud because that's how I can do it. Do you see the media player there? Like it looks like a
No.
video going to play? No?
No, you stopped sharing your screen.
All right, share. Sorry, share. Oh, I didn't. Okay, I didn't. Sorry. Share. Now?
Yeah.
It looks like a scope, right? Okay, then let me see how I can. So I don't know. This isn't. I couldn't find the clip I had, but this was a 1 centimeter tumor. Mostly solid in the left lower lobe superior segment that was actually, if I recall correctly, not PET avid, but concerning because of growth, and the patient was immunosuppressed for heart transplant. So we were really worried what this was. And I removed this as a segmentectomy, and I was just showing the video. This is done robotically. I believe at this stage I'd already divided the vein, artery vein and the bronchus, and I give some ICG. I'm sure you've seen these videos before. It's nothing new, but really always find it very satisfying when you see here it's black and white because I've got a filter on the camera that detects the ICG, and there's the upper lobe and there's the lower lobe, and the tumor I think was sitting right on the fissure, actually up here in there on the superior segment. You see the ICG highlights the still perfused upper lobe and then the lower lobe segments, and we mark out kind of the area of the superior segment, which wasn't particularly large here. So again, you've probably seen that before, but this just gives you a view. And then of course my camera gets blurry there. I'm sorry I didn't prepare the best video for you, but just kind of give you a few clicks there. So now I've marked it out with the sort of cautery, sorry, and we use staplers to remove it. The hilum has already been dissected, so now we have to create an interfissural plane between the superior segment and the left lower lobe. You can use ICG even in the bedside, but you have to have a special sort of handheld device then to visualize where it is. And I don't know, maybe I hear the general surgeons are using it for their bowel resections and so on. I don't know if you use that at all, Olaskander, or other people on the call to assess perfusion of tissue that you're going to resect.
Nope.
No. Yeah, it's not really routine, but it's very helpful for these segmental resections. Very helpful for the segmental resections. Well, I know we're coming close to the end, actually. Do you, maybe 3-5 minutes for questions? Go ahead, Markian, go ahead, please.
Yeah, thank you for the beautiful lecture. I'm going to ask about the patient with severe paraneoplastic syndrome.
Okay.
Could this condition change approach straight to the surgery, or you always try to
Yeah,
treat the underlying
that's a
condition?
great question. So, the one, absent of serious things like carcinoid syndrome, and let's say you thought you had a FEO or something unusual like that, right? So the ACTH secreting one, well, we tried for a while, right, to manage them medically, but truly they were doing so poorly. What they needed was the tumor removed. So their tissues were terrible, but I did have to resect. So I think what you have to think about is intraoperatively, are you going to come to any problem that could make the anesthesiologist's job very hard? So it's a little different than the question you're asking, but I had a carcinoid in a patient who had some question of flushing. So we gave octreotide. I did it as a continuous infusion. You can do it as bolus, whatever you want, right, during surgery, and watch them very closely afterwards. But they just needed to have the tumor resected. That was what was going to solve the issue. That's a good question.
Thank you.
Bodan?
Thank you for the lecture. I'm a general surgeon, but I got a question about post-operative complications. In general surgery, after using endostaplers, we got a really big percentage of post-operative bleeding. Do you have such cases in your practice, and what's your tactic in this case?
Great question. We use the stapler so routinely for minimally invasive surgery, and I usually use a white load, and actually prefer it myself to the gray load, which is the somewhat finer, meant for very small vascular structures. So I do not see increased rates for bleeding. If I have a very small vessel, which I cannot staple, I can use either a minimally invasive, either robotic or thoracoscopic clip applier, or tie it. You can tie it robotically as well, same as you would tie it open. I do not have concerns with the staplers we use. Do you know what brand of stapler you're using?
Brown, but I forgot the name.
So I wonder if one of the problems is, so in general, there's going to be Covidien and Ethicon. And what I've seen in my stapler experience, in the lesser resourced areas, is that you might have the same brand, but you may not have all the colors of the loads, and it does matter. So in the very thick lung tissue, I would like to use as fine of a stapler as I can. I'm trying to, so let's say the standard VAT staplers, which may be similar to what you have. You could use purple color, but you may sometimes need black. If you took a vessel with black or purple, you would have bleeding. You actually need the tan color. Like this is for that brand. So maybe that's the issue more so than staplers itself. It's having the adequate, the precise stapler for the vascular structure is what I wonder.
Thank you.
Yeah. And Alexander had a question, I think.
He probably left.
Okay, no problem. No problem. Sorry to have gone over. I know it is late in your where you are.
He's back. He's back.
I see. I see. Sir, any final questions? Dr. Bierski? Alexander, do you have any questions? Can you hear me okay?
I'm sorry, I have network and electricity problems.
Not at all.
Yes, thank you very much. Do you cover with a flap after right? Oh, I'm sorry.
Is a flap, did you say, do I use a flap?
Yes, do you use the flap on right main bronchus after right side pneumonectomy? And how do you manage bronchial fistula if it appears?
Yeah, great question. Only if neoadjuvant therapy, if radiotherapy has been given. Not routinely using a flap unless there's some question about the tissue quality or vascularity. If a BPF results, it depends on whether it's early or late. Obviously, very early, you can primarily repair it. If late, I mean to do drainage and packing until the space is clean and then revise, usually using a flap at that point. Could be muscle, could be omentum.
And how do you manage a patient with a late bronchial fistula? Maybe after a month of surgery.
Yeah, so it depends on what tissue they might have available. You could use a muscle flap. Intercostal is probably not robust enough. Serratus for the upper, if it's very high, it could be possible. Latissimus is another possibility. And then omentum is commonly used in patients with enough adipose material.
Thank you.
Sophia, did you have a question?
Yeah, thank you for a great lecture. I want to ask you, if you have a patient with a tumor more than 4 centimeters and you decided to perform a immunotherapy, but he also had a bullous disease, like broken bullous during the chemotherapy, what would you do? Do you change the tactic of treatment?
Well, they might have to go to surgery sooner, it sounds like. Maybe they have emphysema, but if they have, their pulmonary function's not compromised, then you could maybe have to change your plan. I think it'd be really difficult to get them through the course of chemo-immuno if they have a persistent air leak.
Can we just put a drainage during chemoimmunotherapy and just continue the treatment and then perform the surgery?
You could try. I don't know what the extent is of the bullous disease. Something we might do here is place an endobronchial valve. Do you have access to any endoscopic therapies for air leak?
No,
Yeah.
no.
Yeah, so I mean, if the chest drain controls the air leak and they're not very, no signs for infection, you can give it consideration, but I think it'll be challenging.
Thank you.
Well, thank you all.
Thank you, Dr.
Yeah.
Yeah, thank you, Dr. Mody, for your lecture, for this great, colorful, detailed lecture about this pretty complex topic.
Okay.
Yeah, so I
Happy
hope
to.
all of you enjoy your evening and stay safe, and see you in another sections. Thank you so much.
Bye.